half of the tympanic membrane. Yes.
Yes, sir, it's visible around the annulus.
Yes. Okay. Go ahead, Ashish.
The
As
clinical test.
as Dr. Jagat Singh has already pointed out on the importance of the history, complete history of the adjoining areas, and that should also reflect in your examination. Okay. So you can
Sir, coming on.
choose. You can choose either way. You can finish with the ear examination first, and then you come to the nose and throat examination. Or you can tell us the clinical findings before you tell us the clinical test findings. You can choose either way.
Sir, I have done nose examination. There is septal deviation to the left, and oral cavity examination and neck examination is normal.
Okay. All right. Do you
Clinical
expect
test.
do you expect lymphadenopathy in this patient? Especially in the post oral area?
Sir,
Hello,
I don't.
Ashish.
Yes, sir.
If you
Sir,
find post-auricular lymph node enlarged, which you sometimes find small lymph nodes while you are giving an incision for post-oral approach surgery, in most of the ear surgeries, we find small lymph nodes come in your incision line. So what is the usual cause of those small lymph nodes seen in the post-oral area? Is it the chronic otitis media which is responsible, or some other factor?
sir, it is the chronic otitis media which is responsible.
No, I would have not asked you this question.
This question was a googly actually. It has got nothing to do with COM. It has got nothing to do with COM. It has got most of the time it has got things to do with scalp.
Scalp infections.
Yeah.
Yes. So, all right. So, we know that your nasal anterior laryngoscopy findings are all normal except mild DNS.
Yes, sir.
Is it symptomatic DNS?
No, sir.
Will you like to attach some importance to your existing symptoms of this patient to your presence of DNS?
Sir, in this patient, the septal deviation is not that marked that that causes eustachian tube function, eustachian tube dysfunction. But if sir, in my case, this is not significant.
All
DNS is
right.
not significant.
All right. All right.
Coming on
So
to
you can
clinical.
also show us the nasal endoscopic findings showing the DNS, preferably in this patient, could have shown us. Anyway, now
And,
let us go towards the clinical
and
tests.
also Dr. Pasi, since he's discussing a COM mucosal type or whatever it is, posterior rhinoscopy is also pertinent in this. To show the eustachian tube, you said there is no eustachian tube dysfunction. To show the anatomy of the eustachian tube, nasopharyngeal opening, either by nasal endoscopy you could have said, or otherwise with posterior rhinoscopy you should have said.
Posterior rhinoscopy, I will not suggest when we are not expecting too much in the nasopharynx. Nasal endoscopy is all right. Posterior rhinoscopy, I would say, is always a very, very unpleasant experience for anybody.
But
So,
there is a DNS. There is a DNS, marked
yeah,
DNS. I don't think
yeah,
so
yeah.
it is.
But nasal endoscope will take care of that. No?
But he has not done that. I'm just
He,
pointing out that he has missed it. That posterior nasal finding, he has missed it. He should have done posterior nasal, whatever way, whether posterior rhinoscopy or endoscopy, because during exam doing posterior nasal endoscopy is also, it is very, very difficult and time consuming.
and Ashish, some examiners may not allow you to do nasal endoscopy as a part of clinical examination.
That's what I meant, that it is not allowed. I mean,
That's right.
not allowed means it depends on the examiner. But we don't have this much of time that you do nasal endoscopy, because some amount of anesthesia will be required, some amount of time will be required. So it is better to doing posterior rhinoscopy. Yeah.
In DNB exam for the case, they are given only 20 minutes.
Yes, ma'am. Time is definitely an issue.
It is definitely because they are simultaneously examining and talking to the examiner. There is not enough time to ask questions.
Agreed. Okay.
And shall we continue, sir?
Let's go further.
Coming on to clinical test, tuning fork test performed at Rene's test performed at 256, 512, and 1024 hertz, which is positive in right ear and negative in left ear at 256 and 512 hertz, and positive for 1024 hertz. Weber's test is lateralized to left ear, and absolute bone conduction test is not shortened in right as well as left ear.
Okay. So what is the overall inference of your tuning fork test?
Sir, my overall inference of the tuning fork test is there is moderate conductive hearing loss in left ear and normal hearing in right ear.
Okay. All right. So what is your plan? What is in your mind? Are you dealing with a surgical case on the right ear? If I ask you for the right ear only first, are you dealing with a surgical case, or you will like to investigate further to take a decision?
Sir, I would go for further routine investigations, and since right ear is
Yes, Ashish, speak.
sir, I would
Continue,
go for
Ashish.
HRC. I would go for HRCT temporal bone to see the disease progression in right ear.
Before that, would you not like to do tympanometries for the right ear? Because the drum is intact.
Yes, sir, ma'am. Yes, ma'am. Tympanometry should also be. Pivotone audiometry plus tympanometry.
Ashish, is your examination part complete?
No, sir.
Let us finish the examination part first.
Okay, sir. Coming on to more clinical tests, facial nerve motor function is intact by both sides. There is no spontaneous nystagmus. Fistula test is negative on both sides, and cerebellar signs are absent on both sides.
Okay.
Questions for
Okay.
examination, sir? Tests?
Hello. Hello.
जी सर.
Yes. Yes, Dr. Jagat.
सर एक चीज और बड़ी इम्पोर्टेंट लैकिंग है पूरे केस में. I gone through the previous slides also. Right. He didn't. Both ears started in beginning were safe basically. Left ear still safe. Right ear changed the condition. And etiology, as I pointed out earlier, there was no history related to vasomotor rhinitis or allergic rhinitis. मुझे नहीं मिला स्लाइड्स में. और जो सबसे इम्पोर्टेंट है, आपको डीएनएस भी मिल गया और कोई पॉजिटिव फाइंडिंग मिला नहीं नोज थ्रोट में. डीएनएस तो है, चाहे वो ग्रेड आपने इसमें मेंशन नहीं किया कि माइल्ड, मॉडरेट, सीवियर, एंटीरियर, पोस्टीरियर, बोनिस और कुछ भी आपने डिटेल नहीं दिया. अब पॉइंट ये आता है कि आपने वेजोमोटर राइनाइटिस का और एलर्जिक राइनाइटिस का हिस्ट्री ना तो प्रेजेंट हिस्ट्री में दिया और ना ही पास्ट में दिया. और मेरे हिसाब से ये बहुत इंपॉर्टेंट है इस केस में. हो सकता है स्टार्टिंग में यही इसके इटियोलॉजिकल फैक्टर हो.
All right. Agreed. Ashish.
Yes, sir.
Hello, Ashish.
Yes, sir. Yes, sir.
See, you should always rule out the history of allergic or vasomotor rhinitis. Though if the
Okay, sir.
patient is actually suffering from allergic rhinitis, he will come out with those complaints as well. Patient himself will come out with the complaints, but if the patient doesn't, we are not supposed to miss it.
Okay, sir.
Okay, you have not mentioned in your history there that there is no history suggestive of allergic or vasomotor rhinitis.
Okay,
Okay,
sir.
point well taken. Now you tell us about the investigation part. You were saying something about HRCT.
Yes,
Describe
sir.
the
I would go.
HRCT.
Excuse me, ma'am.
Describe the HRCT findings.
So on right side there is soft tissue in the epitympanum as well as uh, around the ossicles and the in the mesotympanum.
Okay.
Can you point out which is the right side, which is this thing? Because I think वो picture में थोड़ा
सर रिवर्स हो गया वो व्हाट्सएप
सर ये
करने में
रिवर्स
ना
हो
हाँ
गया सर।
रिवर्स
पॉइंटेड
हो गया ये पिक्चर
सर
रिवर्स्ड
दिस
है
इज
क्योंकि
राइट एंड दिस इज लेफ्ट।
हाँ दिस इज एक्चुअली पिक्चर इज रिवर्स्ड
सर इट्स
लेटरली
हाँ जी सर,
लेटरली रिवर्स्ड। ओके ठीक है।
दिस इज राइट, दिस इज लेफ्ट।
कैरी ऑन कैरी ऑन कैरी ऑन।
Sir, other ENT examination is normal except for
You have
septal deviation to
only
the left.
one axial view of HRCT. You don't have other views. You have only one view of HRCT.
Sir, this is the only picture I have kept in for
Okay,
PPT.
let us see the X-rays. You're showing X-rays also.
शो द एक्सरे
Okay. So what is the finding on the right side on your X-ray?
So on right side there is a seen dural plate, sinus plate, sinodural angle, and posterior bony canal wall.
Can you
And the
use
mastoid.
your mouse? Can you use your mouse to show us where is the
So
dural
this is
plate?
external auditory meatus. This is external auditory meatus. This is the dural plate. This is the sinus plate. This is the sinodural angle.
Okay. What is the difference? What is the difference between left and right mastoid on X-ray?
Can you describe the cellularity of
Right.
both sides?
Sir,
Yeah, that is-
right-sided mastoid cells are more sclerosed than left side.
Okay. Both are not normal, but right is more
More
opaque.
sclerosed. Yes.
Okay. There is no dehiscence or
There is no
breach of
dehiscence.
either sinus or dural plate.
Yes.
Okay. So let us see at the pure tone audiogram also. Okay.
Sir, in pure tone audiogram, right-sided there is normal hearing, and left side there is moderate conductive hearing loss of 47 decibel.
Ashish, can there be a sensorineural component also in the left ear? Is it possible theoretically?
Yes, sir, it is possible to have mixed hearing loss, conductive as well as sensory neural component.
So what is the cause of sensorineural component?
what disease pathology can lead to that?
And there is uh, erosion of the bony labyrinth.
Erosion of? Erosion of what?
Bony labyrinths.
I'm talking about left ear, my dear. You don't have that pathology in this case, left ear.
So left ear, sir, I don't think so. There will be a sensory neural component. It is only conductive hearing loss.
No,
There
there
can be.
can be.
There
There
can
can
be.
be. Why?
There are
You
so
know the
many
disease.
The patient use
projects.
eardrops for a prolonged duration.
How
Ma'am,
about
I didn't
toxins?
get your question. Ma'am, I didn't get your question, ma'am.
Has the patient used eardrops in the left ear for a prolonged duration? Can the eardrops be ototoxic?
Octotoxic.
Okay.
Yes, ma'am. Use of
Infections can
octotoxic.
cause toxins to go to the,
Toxins from middle ear to inner ear.
so the
Good.
hair cells can be
कैसे
destroyed.
हेलो सॉरी आशीष
जी सर.
कैसे कैसे मतलब वो मिडिल इनर ईयर में कैसे जाते हैं
Sir, from the natural openings.
कौन सी नेचुरल ओपनिंग है ओपनिंग तो
Sir,
होती नहीं
round
कोई भी
window. Sir, round window.
राउंड विंडो और कोई डिसेंसी भी है क्या ये भी हो सकता है ना
Yes, sir. Petrosquamous suture
चलो
dice. No, no, no.
Yes.
नहीं, चलो कोई बात नहीं इसमें ठीक है
So in that case,
वो पॉसिबिलिटी
Ashish,
Mainly
my
round window.
Round window.
so when the toxins go in, it is not actually known as labyrinthitis. It is known as labyrinthosis. At that point, if the toxins are only there, ototoxicity is there, and toxins are there, so it is not called labyrinthitis per se. It is labyrinthosis because there is reactive. These are
Okay,
reactive
sir.
inflammatory process.
Okay, sir.
Because even without labyrinthitis, it can occur because of the disease process.
Okay, sir. Okay, ma'am.
Any other factor which can cause sensorineural hearing loss other than the toxins? Toxins of the ototoxic eardrops, one. And is there any other source of toxins? Can there be other source of toxins?
Is the middle ear not
From the
exposed to the interior,
microorganisms.
to the
Bacterial
exterior?
microorganisms.
The infecting microorganisms can also liberate some ototoxic toxins.
That is your bacterial labyrinthitis. But even without labyrinthitis, full-blown labyrinthitis is not there, but the bacteria is there, no?
Okay.
Middle ear is constantly exposed to the exterior. So along with the air dust, bacteria can also enter.
And that is why you said spontaneous nystagmus also, no? That is again the reason the toxins go to the endolymph and then they cause vertigo. So you took the history. So that is the logic.
Yes.
So now you know that there can be a sensorineural component, mixed hearing loss in a patient of mucosal type of chronic otitis media.
Yes.
Okay, let's go further.
Okay. So final diagnosis is bilateral chronic otitis media with right inactive squamosal, with right normal hearing, in left active mucosal disease with left moderate conductive hearing loss with no complications.
Ashish, Dr. Jagat Singh does not appear to be convinced with your squamosal type of chronic otitis media on the right side. Why is he thinking like this? Hello, Ashish.
Yes, sir. Yes, sir. Sir,
Do you
sir,
have
can you
any
repeat the
findings
question?
corroborating squamosal? Can you convincingly say squamosal? Do you have any findings apart from the history?
Ma'am, I have otoscopic findings in right ear, which is showing attic retraction, grade 1 attic retraction in the attic region, and there is long-standing history of the 10 years ear discharge. So the initially active mucosal disease converted into inactive squamosal disease.
That is history, but the retraction pockets are self-cleaning, seems to be,
Self-
right? So that is what sir is not convinced because there are not
No.
very convincing findings.
And also the CT findings.
Not at all.
And also the CT findings are not showing any gross destruction or significant destruction of the ossicles and the possibility of a cholesteatoma.
Because if the mastoid is filled, ossicles, they are expected to have some sort of erosion, some
Sir,
degree of
HRCT
erosion.
shows soft tissues in epitympanum and mesotympanum around the ossicles, which is seen in only squamosal disease.
You mean to say we have cholesteatoma around the ossicles? It doesn't
That need
look
not
like
be cholesteatoma.
you need to do you need to do a further thorough anatomy can be done to see whether it is there or not, or we can have a finer slices of CT temporal bone to comment on the possibility of cholesteatoma around the ossicles.
Okay, sir.
As such, in this single film that you have shown, it is not convincing about your diagnosis of the right side.
Absolutely, sir.
It
Soft
is
tissue means soft
as
tissue.
Madam Dr. Sukhdeep has already hinted that this is seems to be a self-cleansing attic on the
Attraction.
right side. Yes.
So the treatment
So
parts are
if we agree to Dr. Jagat Singh and Dr. Sukhdeep, so what will be your approach towards the management of this patient, and what all are you going to tell the patient during counseling?
So first line management will be only conservative management in the form of oral antibiotics, nasal decongestant drops, oral decongestants, and topical antibiotic drops.
That he has been using for years now. Now this
Yes.
patient has come
Yes.
to you for remedial action.
Sir, I would go for inside out mastoidectomy.
Which side?
Inside out mastoidectomy to see
Which side? Left or right?
right side. Right side, sir.
Right side. Why do you want to operate right side? There is no hearing loss. There is no extensive destruction. There is one term which is called frequent suction clearance. Regular suction clearance in self-cleansing cavities help the patient. The only thing which is required is that the patient should be compliant. Patient should visit you as and when you want him to come, and you do a thorough examination with a microscope each time and do a suction clearance. I don't know whether other
That
experts
is
would agree with my
no,
suggestion.
office
sir.
management. Office
Absolutely,
management
sir.
of
A
cholesteatol.
young
Absolutely.
patient, you destroy the hearing by doing the surgery. It is not recommended. And patient can come for cleaning. Hearing is normal. There is no loss of tympanic membrane. Retraction pockets are self-cleaning. So why do you want to go for a surgery? Cavity problems, all those problems, complications, you have to keep in mind, na? Why would you like to do the surgery? Patient is not giving you those complaints that you end up doing the surgery for that reason.
May I
Neither
suggest
cholesteatoma doesn't mean.
tympanometry right here, and if you get a type B curve, you can put in a grommet. It will help in aeration. There are those
Yes,
pockets
ma'am.
anyways.
Can be done, ma'am. That will take care of the retractions. How about left ear?
Left ear tympanoplast.
But it is
It's
wet
an
yet.
it is active disease. How can you go in for tympanoplasty?
So what do you do if a
Something-
ear discharge does not resolve with management, with conservative management, right? But you think that it is mucosal disease. So what do you do? Before tympanoplasty, it is wet. You can't do tympanoplasty. So what do you do? You rule out the
Cons-
cause. Why is it dry? Why is it not getting dry? So what do? You said send the pus per culture sensitivity.
Pus
You
culture
do other
sensitivity.
things. You rule out the bacteria, then you do the conservative management. You don't jump to surgery with a wet ear, right?
Okay, ma'am.
And
As sir
even
said, you rule out the causes, allergic causes, other causes. Why it is not getting healed? You correct the DNS.
and despite all these things, still the discharge is not getting corrected. You have given the appropriate antibiotic, appropriate surgery for the cause. Then what do you do? What type of tympanoplasty you will do?
Very good, sir has suggested. Think.
What are the indications of cortical mastoidectomy?
You would clear it from the air cells. No aeration. Only then the graft is going to be uptake. No.
Okay, ma'am.
Because this is known as mastoid has become a reservoir of infection.
Infection.
So we have to clear that reservoir. We have to clear
Oh,
this. And so along with tympanoplasty, you will do cortical
Cortical
mastoidectomy
mastoidectomy.
also.
And your mucosal will heal.
Will
And
you, Ashish, will you do both the procedures simultaneously or separately?
The combined approach tympanoplasty should be there, should
No, no,
be
no, no,
done.
no, 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 no,
Active
no, no.
discharge.
No,
No,
No, no, no,
combined
no,
approach
no.
tympanoplasty is a totally different
Don't say
operation.
that.
Don't get confused. That is different.
वो अलग चीज होती है, टोटली अलग चीज है वो कैट.
सर पूछ रहे हैं कि कान में एक्टिव डिस्चार्ज है, अब जो कॉर्टिकल मेस्टोडेक्टमी है और तुमने ग्राफ्ट लगाना है, वो एक ही सेटिंग में करोगे या कुछ फर्क करोगे? अगर कॉर्टिकल पहले करते हो तो क्या होगा? वैसे ही टेक अ वाइल्ड गेस इफ यू कांट, just think about the pathology. Sir is there to guide you.
सबसे पहले सोचो कि एक्टिव म्यूकोजल
when-
डिजीज में आप
if
टिम्पैनोप्लास्टी करते हो कि नहीं करते?
sir, we don't do in active disease.
बस आप बताओ.
Cortical mastodectomy will improve the ventilation, and we will wait. In my opinion, we will wait for the graft placement.
We will wait for the discharge to subside, and it will
Yes.
if that is the disease process.
Yes.
हेलो भाई, तुम आंसर डॉक्टर पासी का जो प्राइमरी क्वेश्चन था उसका जवाब यही तो है कि दोनों साइमल्टेनियस नहीं करेंगे. पहले डिस्चार्ज को ड्राई करने के लिए अगर मेडिकेशंस और कंजर्वेटिव ट्रीटमेंट फेल्स, देन यू प्रोसीड टू द cortical. That process is also for drying. If the discharge is controlled and ear is dry, then you go for tympanoplasty. तो यही तो डॉक्टर पासी ने पूछा था.
क्योंकि वो प्रूव करेगा ना कि वो
दिमाग
म्यूकोजल
सीधा
डिजीज है.
Yes.
सीधा आंसर था ये तो. चलो
सर ने तो इतने अच्छे से खुद आंसर बता दिया था.
चलो
चलो
करिए.
आशीष, अब ये बताओ, प्योटोन ऑडियोमेट्री को दोबारा से खोलो, जरा दिखाओ हमें, ऑडियोग्राम दिखाओ, और ये बताओ कि इसमें जो ऑडियोग्राम में दिख रहा है हमें लेफ्ट ईयर में, उसमें आपको सिर्फ मेरिंगोप्लास्टी से काम चलता है कि ऑसिकुलोप्लास्टी की भी जरूरत पड़ेगी इसमें? यस आशीष.
Yes, sir. Sir, can you repeat the question, sir?
Keeping the finding of the audiogram in mind, left ear, you think meringoplasty alone would be sufficient, or you will have to do ossiculoplasty also?
Sir,
How
if
much loss is required for a perforation? That is what sir means.
ma'am,
परफोरेशन के हिसाब से, लॉस के हिसाब से कोरिलेट करो.
sir, I think maringoplasty alone will be sufficient because of airborne gap.
How much is the conductive hearing loss in the left ear?
47 decibel.
47 decibel. So
Ashish, do
will
you mean type
your
1 tympanoplasty or myringoplasty? Would you not like to check the ossicles?
That's what I was about to ask. आजकल मेरिंगोप्लास्टी तो वर्ड चला ही गया भाई, कोई नहीं
I know it
करता.
is
खाली
used
सिर्फ
loosely
फैट और कार्टिलेज के
interchangeably.
लिए रह गया, बाकी तो टिम्पैनो ही है. चेक भी करोगे
हाँ,
ऑसिकल्स.
जो भी मर्जी कर लो.
when
तो
I
how
say
will you
meringoplasty, I mean tympanoplasty type
टाइप 1.
नहीं, how will you check कि ऑसिकल डिसकंटिन्यूड है या इंटैक्ट है ड्यूरिंग सर्जरी?
The round window reflex आएगा ना sir?
राउंड विंडो रिफ्लेक्स कैसे करता है बेटा? हाउ डू यू डू इट?
Sir, handle of Malleus को sir पुश करते हैं सर पिक से, मतलब हैंडल ऑफ मेलियस.
फिर क्या होएगा? फिर क्या होएगा? व्हाट विल हैपन? कहाँ देखोगे? क्या चीज देखोगे? उससे पहले, करने से पहले आप कुछ करोगे? क्या करोगे? कहाँ
Sir,
पे
we will check the
देखोगे?
mobility of the we will check the mobility of the ossicles. When the handle of Malleus is moved, then incus and stapes will also move
तो वो
if the
कैसे
ossicular
कहाँ देखते हैं? आपने
discontinuity
कुछ
is
वर्ड यूज किया था, राउंड विंडो
round
रिफ्लेक्स।
window reflex.
तो वो कैसे देखते हैं राउंड विंडो
वो
रिफ्लेक्स?
कैसे देखते हैं? और रिफ्लेक्स देखते कहाँ देखते हैं यार आशीष? कॉमन सेंस है।
तुमने राउंड विंडो नाम लिया है तो राउंड विंडो पे ही
राउंड
होगा।
विंडो पे ही
वही
देखेंगे
होगी
सर।
ना।
हाँ तो क्या
राउंड
क्या
विंडो पे
देखोगे राउंड विंडो पे? क्या दिखाई देगा आपको?
सर
ये प्रैक्टिकल
एंटीरियर
सीधा दिख
क्वेश्चन है,
जाएगा।
क्या है
थ्योरी
हाँ
में
वहां
जी
तो
सर।
पे?
दिखा है। हाँ बोलो।
सर एंटीरियर इंफीरियर क्वाड्रेंट में सर राउंड विंडो पे
राउंड विंडो को कवर
आशीष,
कौन कर रहा है?
आशीष राउंड विंडो देखने के
Ashish, don't get
लिए आप
confused.
टिम्पैनोमेटल टिम्पैनोमेटल फ्लैप रेज करोगे या डायरेक्ट दिख जाएगी आपको राउंड विंडो पूरी?
टिम्पैनोमेटल फ्लैप रेस।
उसके बाद बेटा क्या देखोगे? मैडम पूछ रही हैं,
क्या
उन्होंने
रेज
देखते
हिंट
करोगे
भी
ना
दिया है।
उससे।
राउंड विंडो पे ऊपर क्या होता है? एक
और क्या है कवरिंग को क्या कहते हैं?
राउंड विंडो के ऊपर क्या? राउंड विंडो बंद कैसे होती है? अब बता।
राउंड विंडो मेम्ब्रेन।
मेम्ब्रेन होती
शाबाश।
है। वो तो मेम्ब्रेन तो
यस।
दिखेगी। उसका भी एक और तरीका, बेटर तरीका है। उसके ऊपर थोड़ा सा आप अपना
जी जी।
लोकल एनेस्थीसिया का एक ड्रॉप डाल दो, या एक कोई
ओके
ब्लड
सर।
का ड्रॉप डाल
ये
दो।
ड्रॉप डाल लो, कुछ भी डाल लो।
उसका
सेलाइन।
एनीथिंग।
मैंने उसका मेनिस्कस देखो। मेनिस्कस होता है जैसे आप कप में या किसी में शीशे के
कप शेप।
ग्लास में ऊपर का लेवल होता है ना, उसको मेनिस्कस बोलते हैं।
जी
तो वो
जी सर, जी
मेनिस्कस
सर।
दिखेगा।
लाइट रिफ्लेक्शन।
तो मेनिस्कस ज्यादा अप्रिशिएबल है हिलना। अगर हिल रहा है तो बात ही खत्म हो गई। ठीक है
ठीक
ना?
है सर।
इट्स प्रेजेंट।
ठीक है सर।
At
Sir,
the end of a stepidotomy, we always check round window reflex, and in that we add just one drop of saline, and we
ओके
check
सर।
with the movement of the light, which gets displaced with that drop of saline.
हाँ, उसको
Some
मेनिस्कस
some
बोलते हैं, मेनिस्कस।
yes, some
ठीक है।
movement is noticed.
sir,
चलो।
sorry for
Because it's very
interruption.
important in otosclerosis, na? Reflex is absent. So you have to check it
यस
after surgery.
यस।
Sir, sorry for
That
interruption,
is
but
what is meant.
it's
रमन इंटरप्ट
eight.
करके
Yes,
मॉडरेट।
it's 8 p.m.
Fine,
So
sir.
we can conclude in next 5 to 10 minutes.
या
Okay,
प्लीज प्लीज प्लीज।
Ashish, you tell us the steps of cortical mastoidectomy.
Sir, in cortical mastectomy, first of all, we have to infiltrate the postauricular region with the local anesthesia. Then we will give 5 days
Even if
incision.
the patient is under general anesthesia.
No, sir, not in general anesthesia. If we keep the patient in local anesthesia, then we have to infiltrate the postauricular region
ऑलवेज।
with the local anesthesia.
ऑल एज
जनरल
ग्रुप।
एनेस्थीसिया में नहीं देते इन्फिल्ट्रेशन?
यार क्या बात कर रहा है?
जनरल
नहीं
Bleeding
एनेस्थीसिया में भी
कैसे?
देते
आशीष, देते दोनों में
जनरल
देते।
एनेस्थीसिया में भी देते
तो
हैं सर।
उसका
ब्लीडिंग भी तो
फंक्शन
रोकनी
अलग
है।
हो।
ब्लीडिंग
हाँ
कंट्रोल करना।
कोई बात नहीं, कोई बात नहीं। कैरी ऑन। थोड़ा थोड़ा ज्यादा हो गया। उसको थोड़ा रिलैक्स भी
सर
करो यार
हमारे
साथ
जीए
साथ।
वाले ज्यादा फ्रेंडली नहीं है, उसने लोकल ही देखे हैं।
हाँ कोई बात नहीं, लोकल देखा, जीए भी पता होना चाहिए। तो जीए उसमें लोकल एनेस्थीसिया में ऐसी क्या चीज होती है जिससे मैडम ने बोला कि हमें ब्लीडिंग भी रोकनी है?
सर एड्रेनलिन होता है
कितना होता है एड्रीनलिन?
सर। सर हम 1 in 60,000 डाइल्यूशन बनाते हैं, 30 ml 2% जाइलोकेन। उसमें
हम्म,
सर 0.5 ml एडीआर पुट करते हैं, तो 1 in 60,000 डाइल्यूशन।
वेरी गुड। 1 in 60,000, 80,000, जो भी आप करते हो आपके उधर के डिपेंड कर। ठीक है। उसका काम क्या होता है? वेजो कंस्ट्रिक्शन कर देगा एंड
वेजो
ब्लीडिंग।
कंस्ट्रिक्शन।
ठीक है, चलो आगे चलो, आगे चलो।
सर देन सर पोस्ट ऑरिकुलर विलियम वाइल्ड्स इंसिजन इज गिवन 8 to 9 mm behind the retroauricular groove.
क्या
One
क्या
more
काटोगे?
argument for adrenaline. It prolongs the effect of lignocaine.
नहीं, मैडम यहाँ तो जीए हो रहा है ना, जीए की बात हो रही है, तो उसका इफेक्ट लिग्नोकेन का भी
So,
हमें
so what?
देखना है।
Anyway, then saline adrenaline.
हाँ, वो सेलाइन एड्रीनालिन दे सकते हैं। एड्रीनालिन इज मस्ट, बट
हाँ
वो
जी मैम,
वही है।
usually anesthetist prefers that we give saline adrenaline rather than LA adrenaline.
हम्म, राइट। अब आपने इंसिजन दिया,
Okay,
क्या क्या लेयर्स
what
काट रहे
next?
हो
आगे
आप? लेयर्स कौन कौन सी काट रहे हो आप, वो बताओ। क्या क्या लेयर्स कट रही हैं वहां पे?
हाँ जी सर। सर उसके बाद सर स्किन स्किन इंसिजन दिया, देन superficial fascia, then deep temporalis fascia, uh, then we will expose the McEwan's triangle
आपने बेटा बहुत एक अच्छी लेयर मिस कर दी जहां से सबसे ज्यादा ब्लीडिंग होती है। सबकुटेनियस लेयर जो है सबसे ज्यादा ब्लीडर तो वहां होते हैं, उसी को ही
यस
आपको
सर,
कंट्रोल करना है, तो वो भी आपको ध्यान रखना चाहिए।
ठीक है
ठीक
सर,
है।
So
ठीक
you
हाँ
go
जी।
as skin subcutaneous tissue, and that is how you
है।
go.
चलो ठीक है,
Okay.
आगे चलो आगे चलो।
Then McEwen's triangle is identified and drilling is started in the area.
Ashish,
And then we will.
what is triangle of attack?
So triangle of attack is anteriorly posterior bony canal wall, superiorly supramastoid crest or temporal line, and tangent drawn from the supramastoid line is triangle of attack.
And what is suprameatal triangle?
सर जनरली सर सुप्रामेटल ट्रायंगल और ट्रायंगल ऑफ अटैक सर सेम ही होता है सर।
Is the
सर
triangle
सुप्रा
named after some person?
बोला उसने।
मैकइवन्स ट्रायंगल,
There is some difference.
मैकइवन्स मैकइवन्स ट्रायंगल सर।
डॉक्टर पासी,
Yes.
डॉक्टर पासी, आई थिंक प्रैक्टिकली स्पीकिंग ही इज राइट। मैकेवन्स ट्रायंगल और ट्रायंगल ऑफ अटैक सेम होता है। इट इज मैकेवन्स ट्रायंगल इज एनाटॉमिकल स्ट्रक्चर, and triangle of attack is when we open the thing, wherever we are attacking triangularly, that is known as triangle of attack.
Actually, suprameatal triangle we all define correctly, but triangle of attack is the area from where we start drilling. And this is the cribriform region on the cortex of the mastoid bone, which is smaller than the dimension of the suprameatal triangle. So
Absolutely, sir.
uh, practically the triangle of attack is smaller than the dimensions of the suprameatal triangle. The triangle of attack is the place from where we start drilling
Yes.
after demarcating the suprameatal triangle.
एक फौजी से ज्यादा अटैक को कौन जानेगा? So attack is where we start
ठीक है,
drilling.
okay. Keeping the time factor in mind,
I know.
Ashish, tell us at the end of a standard cortical mastoidectomy, what are the anatomical structures you would like to display?
सर सुपीरियरली there will be सर ट्रॉटमैन्स ट्रायंगल।
What are you talking?
नहीं यार, ट्रॉटमैन्स ट्रायंगल
सर
कहाँ
आई डिडंट
पहुंचे?
गेट योर
और
क्वेश्चन
पूछ रहे
सर,
अरे
एक बार कैन यू रिपीट द क्वेश्चन?
At the
After
end of
cortical,
the standard cortical mastectomy, what anatomical landmarks or structures you will like to display? These are the things which must be visible clearly at the end of the standard cortical mastectomy.
that your
that marks,
cortical is beautifully done.
marks the end point of the cortical mastectomy.
Where you stop.
सर posterior canal wall, sinus plate, Tegman plate, mastoid synodural angle, and the aditus,
Medially.
and lateral semicircular canal.
Very good. और
Horizontal semicircular canal. Yes.
नीचे?
Yes, sir. And
नीचे
aditus, नीचे सर
inferiorly.
sinus plate, superiorly Tegman plate.
What about mastoid tip?
Mastoid tip is
तो
inferiorly.
टिप सेल्स जरूर दिखाने होते हैं।
One very important structure, are missing.
Sir,
What is the important structure you are not telling, which is required for cochlear implantation? Posterior
sir,
tympanotomy
posterior
approach.
tympanotomy,
Close to the
facial
dome of the
recess.
lateral semicircular canal. No,
Sir, facial
this is
recess.
a structure which is visible. You have to see that structure before watching, displaying that part. You cannot proceed further for posterior tympanotomy.
Sir, facial recess.
No, facial recess is not visible. It's a recess which is lying inside. We are talking about what is visible through the mastoid cavity.
कोई prominence या कुछ?
The short process of incus in
Incus.
fossa incudis.
Fossa.
Yes.
Okay.
Fossa and
That also has to be seen. And theoretically speaking, the digastric ridge also needs to be displayed lower down.
okay. ठीक है sir.
Okay.
Once the fossa
Okay.
introduces
Can we-
Dr. Raman, how
visible,
much time is
So
left?
can we,
sure of
yes, can we
erection.
conclude now?
टाइम तो
sir?
ओवर हो गया है.
Yes. So can we conclude, sir?
Dr. Raman,
Your
how much
permission?
time is left?
So we are overshooting the time already. It's
Pasi sir ka, I think
8:15.
internet is an issue.
Yes, yes. So we can conclude if all the examiners allow me.
Sir, Jagat Singh sir, shall we conclude, sir?
हाँ
Pasi sir
sure.
is back, sir.
Okay.
Okay, sir.
We can ask
Okay.
a couple of questions and conclude.
How much
Sure, ma'am.
time is left?
Dr. Pasi's internet is a little this thing, so sound is not coming.
Yes, ma'am.
Hello?
Any questions, ma'am?
I think if the time is not permitting, so we can conclude right here.
Yes, sir.
Yes, sir.
Sir, we'll stick to our time. Yeah.
Yes, yes.
Dr.
Okay, we
Bhushan,
can
I
conclude.
have just got a small comment to make. This
Sure,
is this is for the encouragement of the postgraduates.
Ji.
First of all, his presentation was really good. It
Sir.
was the history and all. It was really good. And hats off to the teacher. Who was the teacher who moderated it?
Sir, Dr. Sukhdeep Kaur ma'am.
Dr. Sukhdeep, hats off to you. आज
Thank you so much, sir.
आज गुरु पूर्णिमा के दिन नमस्कार है आपको. इतना बढ़िया आपने इसके प्रेजेंटेशन करवाया है. It is all
Thank you,
these
sir.
questions are to be, questions तो change होते रहते हैं and all, but it was overall a very excellent presentation.
Thank you,
Excellent.
sir. Thank you to all, sir. क्योंकि तो
Sir,
आप सब मेरे
sir.
teacher हो, sir. So it's a teachers day.
Sir, can I say something?
Ashish want to say something. Yes, Ashish.
Sir, आज गुरु पूर्णिमा है सर, तो I want to thank my HOD ma'am as well as Dr. Abha Singla ma'am. She's senior consultant in my department, and Dr. Monica Chaudhary ma'am. She's also consultant in my department, and my co-PG Dr. Dipangshi Rao.
Okay.
So we
Okay.
have a very good team of consultants and residents. All our students are very, very cooperative, helping with each other, and it's a very good day to thank all of them.
Ashish,
Okay.
you can stop sharing your screen so that we everybody can be seen on the screen. Yeah, thank you. I think it was really a nice presentation. And to conclude today's webinar, I would request our president, Dr. Ravinder Gera, to just say a few words and thanks everyone. Dr. Ravinder Gera.
So, good evening, everybody. On part of AOI Haryana, on this auspicious day of Guru Purnima, I will like